Okay.
Okay. Hi, everyone. Welcome to the webinar. A few quick housekeeping notes before we start. First, we will be recording this webinar to post online for future viewing. And second, we will be saving questions and answers until our speaker has finished presenting. For the Q&A, we're using the chat box on the side of your screen to take any questions that you have. Please feel free to type any questions that you have in there throughout. We'll be keeping track as the event goes on, and then we will have a dedicated point for a Q&A. And now, without further ado, I would like to introduce Dr. Tim Kenyon, the Vice President Research at Brock University, who will be providing opening remarks and our land acknowledgement. I turn the virtual floor over to you, Dr. Kenyon.
Thank you so much, Jane. And good afternoon, everyone. Welcome to I Believe in Me, Not OCB, a manualized approach to treat obsessive-compulsive behavior in children and youth with autism spectrum disorder, featuring the research of Dr. Tricia Vause. Today's event is part of the Lifespan Institute Speaker Series, which is a regular series of presentations that's designed to connect and engage with the community around research that's going on at Brock. Support for the event has been provided by Brock's Faculty of Social Sciences and by the Office of Research Services. And we begin this gathering by acknowledging that the land on which Brock University rests is the traditional territory of the Haudenosaunee and Anishinaabe peoples, many of whom continue to live and work here today. This is territory covered by the Upper Canada Treaties and is within the land protected by the Dish with One Spoon Wampum Agreement. Today, this gathering place is home to many First Nations, Métis, and Inuit peoples. Acknowledging this reminds us, among other things, that our great standard of living is directly related to the resources and friendship of Indigenous people. Obsessive-compulsive behaviors show up in many different ways. An exaggerated avoidance of germs, repetitively wondering or checking whether the door is locked, placing things in a particular order, counting objects over and over again. These and other incidents may sound familiar for parents of children living with autism spectrum disorder, or ASD. Typical obsessive-compulsive behaviors that some ASD children exhibit may include frequent hand washing, ordering and arranging, seeking reassurance, and carrying out rituals in day-to-day living. It can be overwhelming for children to understand obsessive-compulsive behaviors, or even to find the right words to express what they're going through. And it's also overwhelming for parents to understand obsessive-compulsive behaviors and to help their children navigate the condition. Brock University is very fortunate to have researchers and their teams who investigate the many manifestations of autism spectrum disorder. Their many years of research, scholarship, and working closely with families, children, and young people have informed their expertise on the nature of ASD. Expertise recognized by such bodies as the Ontario Association on Developmental Disabilities, the Government of Ontario's Clinical Expert Committee for Autism Spectrum Disorder, and the Ontario Association for Behavior Analysis, among others. Their investigations lead to practical, implementable strategies for parents, caregivers, children, and youth living with ASD. These programs make a huge difference in people's lives, with many families experiencing breakthrough results. Now, in a session held at the beginning of this month, Dr. Maurice Feldman, Dr. Julie Kudis, and Claire Shingleton-Smith described early intervention programs that they had created through their research. Today, we're very privileged to have with us Dr. Tricia Vause and Dana Kalil, who will share with us their novel research, their research and the treatment package that arises from it for children and youth with autism spectrum disorder who exhibit obsessive-compulsive behaviors. Their treatment package, which blends applied behavior analysis with cognitive behavioral therapy, is called I Believe in Me, Not OCB. Cognitive behavioral therapy can be effective in addressing anxiety, while applied behavior analysis can illuminate or mitigate other factors contributing to the presence of obsessive-compulsive behaviors. Our researchers will explain to us how and why blending these two approaches is so powerful in equipping children and youth with various coping strategies. These strategies then become part of their toolboxes that they can use for long-term empowerment and change. All of this is done in a fun, welcoming, and safe environment. Leading this breakthrough research is Dr. Tricia Vause, along with colleagues Dr. Maurice Feldman, Dr. Jan Freiters, and outstanding student researchers. Dr. Vause is Associate Professor in the Department of Child and Youth Studies and a board-certified behavior analyst doctoral. A clinical psychologist, Dr. Vause is interested in behavioral assessment and treatment for children and youth with autism spectrum disorders, as well as dual diagnoses of ASD and other challenges such as anxiety and obsessive-compulsive behavior. She's worked at medical counseling centers, residential training facilities, and school-based programs in both Canada and the United States, conducting research and clinical work with these children and youth. The research Dr. Vause is discussing today was funded by the Ontario Mental Health Foundation and the Ministry of Health and Long-Term Care. Our student presenter, maybe that's getting ahead of ourselves, but our student presenter today is Dana Kalil, who's a second-year master's student in Applied Disability Studies. Although our two presenters will be sharing their research results and their insights, this webinar isn't meant to recommend any specific resource or treatment options, nor is it intended to provide individual advice. You can tell the lawyers had a hand in this. Individuals should consult with their personal healthcare team or treatment provider for all healthcare recommendations and decisions. I think that hopefully goes without saying, but we'll say it anyhow. I'm delighted to turn the floor over to Dr. Vause. I'm looking forward to this enormously. Please enjoy the webinar, and thank you so much for joining us.
Thank you very much. I'm delighted to be here today to talk about the research that we've been doing in our lab for a number of years, looking particularly at developing a manualized approach to treat obsessive-compulsive behavior in children and youth with autism spectrum disorder. Dana Kalil, as well as Sarah Davis, my master's and my PhD students, contributed a number of slides to this presentation, as well as a number of ideas, and were very helpful in terms of putting this whole treatment program together, as well as a number of other graduate students that I'd like to acknowledge. So let me just start out by, I'd just like to personally thank the Ontario Mental Health Foundation, as well as the Ministry of Health and Long-Term Care. This research, this randomized controlled trial could not have been done without the funding that we received, as well as a number of Match of Mind scholarships that a number of my students received to participate in this research and do some clinical work alongside that. I'd also like to, just like I said, specially thank the number of undergraduate and graduate students in our Brock lab within the Lifespan Center. I'd say over the course of this trial and case studies leading up to it, close to 20 students, if not more, participated within this OCB research. It may have been for a practicum, collecting hours towards becoming a board certified behavior analyst as a volunteer, as well as doing theses, whether that be bachelor's, master's, PhD dissertations. So, this was really a team effort in terms of putting this manual together and working with the wonderful families and children and youth that we were privileged to work with. And that's who I'd like to thank next, or last, is an extra special thank you to the children and youth and the parents who participated in this randomized controlled trial. To the children and youth, they were brave, they were courageous. It's difficult, and I'll get into this in just a second, to deal with these obsessive compulsive behaviors, these things that control often a large portion of the day in terms of an individual's life, as well as the family's lives. And so I just want to send a special thank you out to these individuals in terms of their participation and their bravery and really bossing back obsessive compulsive behavior. Okay, so I'm just going to start by labeling just a few of these behaviors. Now, when we talk about obsessive compulsive behavior, I could name, so many in terms of different things that go on and different things that are interfering in terms of individuals' lives. I've chosen some that we've seen in our lab or in our research, in my clinical work, that are quite prevalent in terms of children and youth. So you see in the top left-hand corners of a picture of a backpack. So that could be something like checking things over and over. There's often there's two flavors to OCD, okay, or obsessive compulsive behaviors. So we're looking at kind of a worry that something bad may happen. So I have to go compulsively check something over and over again. And it's also, and the other flavor is kind of that not just right. I don't feel right unless I go do that. Something in my body doesn't feel right, right? And so then being able to go do that thing, whatever it is, that compulsion, that then in turn relieves the anxiety. So those are the two flavors we're looking at. So you're going back to the backpack, it might be, again, checking over and over. You can imagine if that's done morning, day, and night, how much time that takes in terms of an individual's life. In the bottom corner, you see, for example, the young boy talking to an adult. And, this could be seeking reassurance. And this is often one that a lot of children and youth struggle with in terms of needing repeated reassurance. So a child may ask once and then need to ask 5 minutes later, or even 5 seconds later, and ask again and again and again, even though they have the answer. And again, it could be one of those two flavors when it comes to the obsessive compulsive behavior. In the middle, I put the picture of a pillow. So that could really represent something like stuffed animals that need to be, lined up and ordered, and they can't be moved in any way. Or something like pillows where they have to be in a perfect manner, and it may not be perfect in the way that, everything is lined up the way, in terms of symmetry. It could be that, but it could also be the way they need to have it. And sometimes that can take minutes to hours to be able to rearrange. And can you imagine if that's happening on a daily basis? And then we see the center one with the kids in the car. This is a very, very common one, which is the need to sit in the same seat. And you would think that's not a big deal, but for a number of families that I talk to, it is a big deal because it causes issues in terms of siblings, in terms of just, day-to-day life of needing, having extreme anxiety if that seat is not available to an individual. So, in terms of time constraints, I can't get into all the details around that, but I'd like to talk about, why that may happen, and then further what we do in terms of treatment. Finally, on the right-hand side is one I think everybody can relate to when they think of OCD. They think of hand washing or blowing one's nose, or it could be a child has to get a parent to smell their hands, for example. Being scared, so scared that there's germs, they're going to get sick. Maybe an insect has bitten them, and that's going to lead to contamination. So we call those behaviors contamination-related behaviors. So you see, there's a broad spectrum of behaviors that we're often dealing with when we're talking about OCBs. And these, I just want to mention, are, they map onto obsessive compulsive disorder in terms of what you typically see when you're looking at obsessive compulsive disorder and screening measures. So think of what I just said. Now I want you to consider the challenges of ASD, and by no means does every child with ASD have all of these challenges, right? But these are the things we commonly see. So you have one is a limited verbal repertoire. So it could be having a lack of introspection, or really just not knowing the thought that is behind the behavior. So often within our lengthy assessment, I'll say, or one of our independent assessors will say, well, why do you need to do that? And often the child's response is, I'm not sure. I don't know. I just need to, right? Which often creates more anxiety. Often what we do see within treatment and as treatment progresses is that children start to open up and they start to realize those thoughts behind the behavior. Again, if a thought is present, keep in mind with a number of these behaviors, it could just be the compulsion. And I'll explain that in a little bit more detail in just a second. The next one is a need for social interaction. So when we talk about the core symptoms of ASD, we know that individuals are often challenged with social interaction and social skills, which is an integral part of our package. But in terms of the social interaction, often what we see with these compulsions is individuals develop a sort of a complex verbal repertoire. For example, need for reassurance. It may be that that would become sort of a verbal piece that an individual engages in that not only serves the function of relieving anxiety, but also gives that individual the opportunity to engage in a conversation with a parent or with a sibling. Okay, so this is where we're now talking about the complexity of this, because it's not just anxiety. We often see that there's perceived other functions that are operating when individuals engage in these behaviors. And then the last one is one that I see that is just difficult, I find, when I'm doing the assessment and also throughout treatment, is just that fear of embarrassment, right? I don't want people to see me doing this. I'm embarrassed that I actually engage in this behavior, and they try to hide it, and so therefore they may not want to talk about it. Okay, so you think about this layering, right? So you have the OCB, but you also have that overarching ASD. So, and this becomes, again, a complex piece to be able to figure out, especially with the number of behaviors that children often experience. So I'm just going to spend a few seconds here, maybe a little bit more than that, on this slide, looking at sort of these core areas, right? The two key domains from the DSM-5. So when it comes to looking at ASD, we're looking at social communication as being one of the core areas, right? So the expressive and receptive communication, as well as a number of social skills, right? Which, I'm not, for the purposes of this presentation, going to get into huge amounts of detail in. The area that I really want to focus in on is this so-called restrictive and repetitive behavior, right? This is the other core area that we see in ASD in order to fulfill the criteria. And there's a lot of research pointing to a number of these behaviors being hypothesized as anxiety-driven. And in fact, a number of studies pointing to things like sameness, ritualistic, compulsive behaviors, all loading on the same factor. So this is the area that I'm interested in, my lab is interested in studying, is these so-called, what we call higher order repetitive behaviors. And again, like I said before, that map onto kind of obsessive compulsive disorder when you look at the symptoms included in standardized measures for OCD. So quick review of the literature, not going to spend a lot of time here, but cognitive behavior therapy is recognized as a first-line treatment for pediatric OCD. A number of manuals out there, well-established research, first line of treatment, right? When we think about the core components of CBT, we're talking about psychoeducation, cognitive behavioral skills training, as well as the kind of that key active ingredient, which is exposure and response prevention. I'll be getting into detail about these in just a second. The thing I want to point out here is that limited research exists on evaluating different treatment packages for obsessive compulsive behavior in children and youth with developmental disabilities, intellectual disabilities, and autism spectrum disorder. In fact, we did a review quite some time ago, so in 2014, but again, looking at the literature, there is still limited research within this particular area. And the question becomes, for these populations, what would be most beneficial? So one study I'd just like to point out quickly, and it gets to one of the core pieces of our manual, is a case-controlled study done by Murray et al. In 2015, which was a standard CBT package, small sample, 22 youth, and they were assigned that they were in two conditions, right? So you had kids with ASD and OCD, and then you had kids with no ASD, so just OCD, right? And what happened in the study? Well, what happened was the Child Yale-Brown Obsessive Compulsive Scale, which is one of the kind of gold standard OCD measures, indicated a positive treatment response for both groups, but statistically significant decreases in remission very different in terms of percentages, right? So you see, where ASD is present, 9%, where it was just OCD, 46%. So we really need to focus on these specialized populations. And when thinking about that, really need to think, what do these populations need, right? And the recommendation, and this is a recommendation across, a number of universities, a number of individuals working on this, is further evaluation of adapted or enhanced CBT or cognitive behavior therapy packages. So that need to adapt, right? So I just want to quickly go over, there's been a number of case studies using experimental design, so having careful experimental control, a number that were done in our lab, a number of my graduate students who published research in this area. And, when we look at adapted CBT, we're looking at things like increased use of visuals. And this makes sense when you think about autism spectrum disorder and a number of the core challenges that children experience, right? And you also think about the obsessive compulsive behavior. Things like repetitiveness. So you want it to be repetitive, but you also want to gradually introduce that predictability over time. A protracted cognitive component. Now, this is done on an individual basis. We want to include a cognitive component, but what makes sense for each child and youth, right? What does that child or youth want? What do they want to talk about? So that gets into the youth voice also, and that's something that's really important within this manual. Parent participation, that is a huge piece. So parents come to every session. They also do some homework along with the kids. They're there to support the kids. The therapists are there to support the kids. And then they go home and they practice the exposures with the children and youth, if the children and youth want that, right? Some would like to do that by themselves and so on. So it really is up to the child or youth themselves. Overall, collectively, the studies show clinically significant decreases in OCBs. So that's a good thing, right? So, but there is a need to establish efficacy of adaptive treatments focused on OCBs and ASD. So I've now talked a little bit about cognitive behavior therapy, and we talk about blending. We really wanted our treatment to look at cognitive behavior therapy, adaptations, and now I'm moving quickly on to the last piece before getting into the nitty-gritties of my manual, which is, or our team's manual, which is behavior analytic treatment, a huge piece. So how does this contribute? So how about behavior analytic treatment and function-based assessment? Function-based assessment being the piece I'm really going to focus on. So really trying to get at those things. What is it that's maintaining that obsessive compulsive behavior? Why does an individual need to engage in it? What is the motivation for engaging it? And there's a number of studies that have occurred, again, and a few that we've done in our lab and a number of other studies done in the field of applied behavior analysis to really get at those function-based pieces. So it could be sensory related, it could be attention, it could be escape related. So really looking at those pieces along with that kind of relief or escape from anxiety. So this is just extra information in terms of the RCT. I'm going to go over it quickly, but for those, some of you may be interested in it, so I wanted to present it. So again, blended approach. We called our treatment functional behavior-based cognitive behavior therapy. And in terms of our sort of some publications, a number of case studies that then followed a preliminary RCT that we finished in 2018 or published then. And then our full RCT in 2020. And I just want to quickly go over the design. So we use an RCT, as I said, with pre-post, a number of lengthy assessment measures to really get at the OCB so we could see if they were decreasing, right? And we had independent assessors that worked with the children, youth, and families. And then we also had 6-month follow-up and extended follow-up from that, which I'll get into at the very end. We also wanted to do an analysis of parent rating. So it's one thing to do standardized measures, but it's another thing to also have parents, which was wonderful that they were able to dedicate their time to not only, being there for their child, but also to filling out parent report pieces on a daily or weekly basis, whatever was made sense in terms of their family schedules, in terms of how they perceived the behavior, how it was going, right? And in some cases, if it was possible, we also had the child fill this out. In terms of participants, we had 37 children that we treated. We first started out, we randomized the children. We had 19 in the experimental group and 18 in treatment as usual. So we just said, do whatever you normally would do, right? And then from there, when we finished the randomized controlled trial, we then shifted or moved the treatment as usual kids into treatment. So everybody received treatment. The children and youth were between 7 and 13 years of age with a mean of about 10 years of age. IQ was about 95 or 94.56 in the, if you see in the experimental group. So in the average range, we really were working with individuals with high functioning autism. Since then, we have also done studies looking at individuals in other ranges, and we've come out with comparable results. So we're also engaged in a number of other studies at the moment around that. In terms of measures, I'm not going to go through all of these measures, but I do want to point out that we did use sort of the standardized like Child Yale Brown obsessive compulsive scale, so it was comparable. We could compare to other studies, the repetitive behavior scale, as well as quality of life measures, very, very important. We want to decrease the OCBs or obsessive compulsive behaviors, but how does this increase or how does this affect quality of life for the individual as well as his or her family? How do they perceive that it's helping, right? So just to give you an idea of the measures that we used. So in terms of our overview of methods, so you see on the right-hand corner, in the sort of right-hand side, this is the cover of our children's manual. So we're super excited, our whole team, along with Dr. Feldman and Dr. Freiters and a number of graduate students and undergraduate students. Really everybody came together as a group effort to put this manual together, and kind of in different stages and really tweaking it all along, and kind of in the later stages in terms of getting to the point of publication. So it's called I Believe in Me, not OCB, as you know. And this, like I said, is a children's workbook. And then we also have a clinician's manual that we're finalizing to accompany that. So in terms of the treatment, we designed it as a 9-session treatment, 2 hours each, and 2 therapists. So we had a high therapist to child ratio. Very important when working with this population and these particular behaviors. So we had 3 to 4 children that were assigned to each group. And in terms of the behaviors, you can see, I mean, it wasn't just one behavior or 2 behaviors. The mean that we were working with, when you think about kind of really interfering behaviors that have been going on for some time, so the mean was 6.25 in terms of the different types of obsessive compulsive behaviors that were present and that the children were working on, and it ranged from 3 to 10. So quite a number there. In terms of treatment components, and I'll go over each of these, we started out with phase 1. And again, this is not something I just want to say that we invented ourselves. We adapted a lot of it, was inspired from previous workbooks and work done by other researchers in the field. We just kind of put our own spin on it and also added in the blending piece, or the 2 kind of big pieces, I would say. So phase 1 was a psychoeducation and mapping. And that was really familiarizing children and youth with obsessions and compulsions, and really getting them to be able to, there's a number of things that often we'll talk about when we're saying these are things that are troublesome to us. But what are the things that we're actually going to focus on? And in fact, are they interfering to you? Is it something that you want to work on, right? So that was the focus in that piece. In terms of phase 2, individualized treatment, and the key being individualized. Every behavior had its own protocol, right? Every behavior, say there were 6 behaviors for one individual, each one had a different protocol that was gone over prior to beginning the session. What it included was the function-based piece, which is an integral part of our treatment, which is the function-based assessment and intervention. And that included some indirect interviews that also included ongoing monitoring and assessment of what happened before the OCB, what the OCB looked like, and what happened after the OCB. On top of that, we also did cognitive behavioral skills training. And again, that I talk about in a slide called kind of different strokes for different folks. So we kept it loose on purpose because we wanted kids to pick out what is the thing that works for me in terms of bossing back these obsessive compulsive behaviors, because I'm in control, I'm empowered. Those are the words we often use and the words that we kind of heard over time as the sessions progressed. So we taught things like relaxation, or a child may have used karate moves or sat next to OCB and just said, scram OCB. So those sorts of things. So what they felt worked for them, like I said. And then we also included the cognitive restructuring as we could, and self-statements around different things they could say to themselves instead of engaging in the compulsive behaviors. And then the last piece, exposure and response prevention. So that would be preventing the individual or the individual made a goal, I guess is a better way to say it, to not engage in the behavior or to engage in it a limited number of times, and to be brave enough to expose themselves to the thoughts, the stimuli that were scary, right? So this was something, again, that I give them a lot of credit for, and it was so rewarding to see the progress being made each week. We included parent training modules. I'll talk about that in just one second. So in terms of individualizing the package, I'm going to go over this quite quickly because I want to get onto the treatment package itself. I mentioned the repetitiveness and the predictability of treatment and the concrete exercises. You see on the side, we had rules, we had token systems, we had things that children and youth could earn that were personalized to them for engaging in different behaviors that we rewarded, right? And sometimes they gave themselves a reward. And you see on the bottom piece, that was like a social skills piece where they were doing some exercise, engaging in a social skill, and we also took those social skills and hierarchically ordered them so it made sense in terms of kind of hitting a number of different things in terms of one treatment. So, you know, the question was, could we decrease the OCBs, but could we also work on some of the other core pieces, one being social skills, okay? Within session rules were used, and the use of a token system, like I mentioned, immediate and delayed reinforcers. So this was something that I'll show you in just a second on one of our key sheets, but we did, in addition to using the token board, we also had parents and children together, and we relied on the kids to be able to come up with the things they wanted to work for. What is the thing that I'm going to work for if I'm able to achieve my goal? And then, of course, looking at fading that out and making it very natural in terms of things that controlled that behavior. So it got to the point where we weren't using anything at the end of treatment. Incorporating the children's interests, so important in terms of this treatment or any treatment, right? So looking at using visuals that a child could relate to and that the child enjoyed and liked, right? Different stickers. We'd ask, what sticker do you want next week, right? What's your favorite character? And then there were the social skills exercises, as I mentioned. And, you know, that's part of our manual in terms of having a social skills bank, so that we can start with some stuff that is very basic and then move on to things like kids taking pictures of themselves and, you know, forming play dates and so on by the end of the treatment. So again, making it a very holistic treatment, I guess you would say. So working on the OCBs, but also making it fun, right? In terms of different games that were played and social skills exercises that were carried out. So the key being providing structure and predictability by following a general program structure. Structure we know is important, right? But over time, gradual changes were introduced. So again, like I said, I can't emphasize enough, creating that fun environment, right? Something where the kids want to come back every week. And that was always a check-in point that we did at the end of each session was, are you excited about coming back next week? Or sometimes the kids would say, I can't wait to come back next week, or bye so-and-so, I can't wait to see you again next week. So forming friendships and, looking forward to the next social skills piece. Not necessarily looking forward to working on an obsessive compulsive behavior, right? So we had to integrate that into the treatment very carefully, but they did look forward to talking about their progress. So this is phase one, psychoeducation, as I mentioned. So I introduced all these things, and now I'm going to go through them with pages from our workbook. So becoming aware of compulsions and obsessions. And this piece is really just, like I said, writing out compulsions and getting kids familiar with them. And if there was a thought, also writing that out, right? And again, using different modalities. If the child wasn't able to print, we'd have the parent do it, or we'd have the therapist do it. So using different, whatever worked for that particular child or youth. In this piece, we also started to introduce the bossing back OCB. In other words, you're in control. You can do this. You have the power. And what child doesn't like to hear that? So we see here, this was a lovely girl that I worked with a very long time ago. And, she's in the middle here, and she's, you see the big shield and the big sword. These were things she was very interested in. You see the mummy on the right-hand corner. And what she was really trying to tackle and show us, done totally independently by her, was they were fighting back the germs. So really using these types of pieces to be able to get at and help children and youth to understand what they were doing, okay? And another key piece developed by one of my graduate students was mapping behaviors. Again, part of a number of other manuals, this is how we did it. So we used just simple sticky notes, right? And we had kind of the me zone, the OCB/me zone, and the OCB zone. And the whole idea of moving it from OCB zone, which is I have no control over doing this behavior, right? Like sitting in the same seat, to I have some control. I'm somewhat in the middle, to no problem whatsoever. I have complete control. I'm the boss, right? And you wouldn't believe how excited. I think that was the one thing that I noticed, that was so interesting to see every week when they came, that they just wanted to move that sticky, right? And even if it moved to the border and just moved over an inch because they made a little bit of progress, they were so proud of themselves. So, the other piece is believing in myself. So like I mentioned in that psychoeducation piece, being able to look at, different statements they could say. So it could be scram, it could be beat it could be, go away OCB. And they, personalized these things and got more creative and more inventive as they went along, and really had fun with it, which was great to see. Phase two, this is where we hypothesized that we would see a drop in the OCBs. And this is where we're looking at the individualization key word in terms of the treatment, and really looking at that function-based piece. And that's where we use the questions about behavioral function, or it could be another indirect assessment, as well as ongoing monitoring using descriptive behavioral assessment. And again, looking at the setting events, the motivation, and so on around that behavior. Why do I need to engage in that? And if you look at this bottom one, I won't go over both, is say the need to tell on sister and dad. And that could be something, I'm afraid something bad's going to happen if I don't go tell right away, right? And so what are the perceived functions on top of anxiety? There was clear anxiety present for this particular individual, was getting that attention, right? So we worked on withholding attention, on telling, right? Redirecting to coping strategies, in this case, a social story, as well as, and providing minimal attention. And then on top of that, teaching conversational skills, engaging in functional communication training, looking at appropriate conversations, those sorts of things as replacement behaviors. Cognitive behavioral skills training. So again, this is a piece from our workbook. And you see here, we kept it very loose with the little statements. You saw that on a different slide: beat it, scram OCB, as well as things like, I can do something else, or I can just sit here and let OCB fade away, or I can talk about my favorite things, right? So that falls under the positive self-statements, which you see in the middle in terms of these 3 bullet points. Like, I can do it. I'm not going to let OCB beat me, right? So coming up with these statements that were based on that particular behavior, personalized, and so on. And then having those externalizing statements also, the top bullet, I don't have to listen to you, OCB, scram, right? And then the challenging faulty assumptions. So I'm mainly focusing on the cognitive pieces. So that was kind of our umbrella piece. So if we could go there, and we could with a number of individuals, really getting into that cognitive restructuring piece in a number of ways, And then from there, being able to derive those concrete coping statements. So for one individual, it was brushing my teeth for 3 minutes rather than 20 minutes is enough to get them clean. 20 minutes was our baseline. You can imagine how much time that took up on a daily basis for that particular individual. So just a quick slide here, diaphragmatic breathing. We use different types of techniques, but one, whatever, I say different strokes for different folks. This sometimes works and sometimes doesn't work. But for Charlie, who is 9 years old, he loved this. He would lie down on the ground and he would do diaphragmatic breathing. And in fact, he would call it sweet tarts. And he kind of, as his stomach went out, he'd say sweet, and his stomach went in, he'd say tart, right? So the idea of empowering kids, right, to come up with their own techniques, call it what they wanted to call it. So individualized cognitive training, we see here, and again, this is building from the young girl that was focusing on the germs, right? Is the idea of having bacteria, viruses. She drew this out completely independently. The idea we have these, but also that there are good germs, right? I won't get into detail here, but we spent a lot of time doing pictures and being able to use these things as mechanisms to be able to teach different pieces. So just a few examples of the stairs of learning. So things like for this one, it was sneezing and coughing for one individual. So this individual wrote it out himself, and he had things like the boss back OCB. So enough, you're fired, stop right now. And he decided to go cold turkey. Some kids just said, I just want to get rid of this thing, right? So each step represented a day, and then they practiced, and the check marks represented exposures. So just to give you an idea of the different kind of hands-on things that we did. Telling on himself. So this was another one, and this was where we did it graduated, right? So we did it to fit the need of the child, gauging anxiety, gauging motivation, and so on. So it could be that his baseline was 4 times that he did it in a day. And so we moved to 3 times, to 2, to 1, to 0, right? In terms of the number of times that he would tell on himself. And then he'd have his coping strategies embedded in that. Parent training component, we did a lot of behavioral skills training. I won't go into extreme detail here. We spent a half hour of the hour and a half while kids were working on social skills and snack time and so on. We did focused training with the parent. And so we got into etiology of OCB, into the function-based pieces, looking at CBT skills training, really teaching different core skills that then could be brought back to parent-child dyads and working on a specific OCB and really seeing whether the child could also be independent in that piece. And we had acceptable treatment adherence throughout all of these pieces. I'm not going to spend a lot of time here, but for those of you interested in knowing our 4 primary measures, we did have our statistician, Dr. Jan Freiters, do a number of models. So, and he, in terms of our Hedges G, I mean, with a small sample size, we had quite large effect sizes in terms of across these 4 measures. And then in terms of the behaviors and looking at parent ratings of OCB severity, you see as predicted, when we went into the individualized intervention, that is when we saw the drop in terms of the OCBs, right? And we can see that, again, it's not perfect, but we treated over 100 behaviors. And in terms of the individualized intervention piece, we got it down to, for 66% of the behaviors, to 1 or 2, kind of indicating it's not there anymore. Right? So that was really positive to see. And now what we're doing, we're in the midst with Dr. Fellman, Dr. Freiters, and Dr. Nicole Neal from University of Western Ontario, as well as graduate students, putting together a 5 to 7 year follow-up. So we've now followed up a number of these individuals and used a mixed methods approach using qualitative and quantitative methods. And just to show you here, and this was a slide actually that Dana Kalil, who's here today, was a big part of this study and put together this particular slide in addition to others. And it generally shows, you can see on the left-hand side that, in terms of post-intervention, that's where we ended the RCT formally. And then we did the 5 to 7 year follow-up. There was no statistical change 5 to 7 years later. Okay, and then we've done some modeling and so on, or Dr. Freiters did. I won't take credit for that. And we're not seeing any changes when doing some more advanced statistical methods. Also, the qualitative piece, and it's just a few things up here, but just to give you a flavor of different things, like the youth one. said, I don't have these compulsions anymore. I felt free. Now this is kind of 5 years later, 7 years later that we're following up, right? And then the parent saying, I was surprised how long the effect of the therapy is. So, quite encouraging to hear. So finally, I'm going to wrap up in terms of discussion and future directions. This is the first known RCT of a manualized functional behavior-based CBT to focus exclusively on treating these really complex behaviors, these OCBs, right, in children with autism spectrum disorder. We did see a significant reduction in OCBs, both when looking at standardized measures and doing statistical analyses, as well as when looking at general parent rating scales and looking at, did behaviors get better week to week, right? So we wanted to look at both. Doing that functional behavioral assessment, very, very important. I mean, it's important that we obviously, one of the main ingredients was the CBT piece, but also ensuring that we were able to get at those other controlling variables for the behavior. And then design a package that we put together that was very comprehensive in dealing with these sorts of behaviors so that we could get it completely down in most cases, or in the majority of cases. There is a need to expand to other populations and different methods of delivery. Again, this was a group treatment. We've done a little bit of individualized treatment or individual treatment. Family treatment needs to be done. We need to look at a number of different things in terms of extending to other populations. So whether it be, and we've done a few case studies looking at individuals with intellectual disability, developmental disabilities, and ASD, and also going into that the extended sort of age range in terms of going above 13. I know what came out of the 5 to 7 year follow-up was the need for more packages to work at that level, right? Because of course, things that, that we develop for 7 to 13-year-olds are not going to be applicable for adolescents, right? Or, as children and youth get older. So also looking at that. And then treatment dosage, 9 sessions, does that make sense? Is it better to do a more intensive piece? Is it better to do an hour and a half versus 2 hours? So a lot of those things need to be further investigated. Do we need more booster sessions? And then finally, knowledge to application, so important. And we're in the midst of doing a number of presentations at international conferences and really trying to get this information out there clinically, as well as moving on to a multi-site study where we want to do a much larger effectiveness study to really look at this function-based behavioral treatment for OCB. So that's all I have. Thank you very much.
Thanks so much. I'm just gonna hit end here so we go back into
Wonderful.
Big video for everyone. Thank you so much, Dr. Vause. That was a great presentation. And so we are going to do Q&A now. I know that some questions have been coming in throughout the presentation, and we also received several questions with registration. But if anyone that's watching, if you have a question, now is the time to go ahead and submit it in that chat box. For our first question, it's actually one that came in during the event, and it was, are copies of this manualized program available for purchase, or are they accessible for agencies or educators? How could people get their hands on this?
Right, very good question. So we are working, our team is working as hard as we can. We're actually putting, the children's workbook is done. We're putting the final touches on the clinician's manual. So I'm hoping by the end of summer, we will be able to have this out.
Great. And maybe what we could do is when it does come out, I could email everyone that registered for this event with a little update that it's available so that everyone.
That would be wonderful.
Great. A question that just came in was, did children have formal independent diagnoses of both ASD and OCD or OCB, or were the OCBs part of the ASD diagnosis?
Right. Yeah, that is something we've written a number. If anyone is interested, by the way, I can send some of our papers, because we've written a number, because that's such a complex question. I couldn't get into it in terms of this talk. Long story short, the way that we're looking at it, and other people look at it differently, everybody disagrees when it comes to how to look at ASD and OCD. I see it as being, not in every individual, but in many individuals subsumed under the diagnosis of ASD. That's the way that we're operating, the way the package is operating. However, there is, are instances where you definitely would diagnose a comorbid OCD with ASD. So to answer that question directly, most kids came in with diagnosis of ASD, but not OCD. And that was something that we did as part of our assessments.
Great. Another question was, this person says, I'm a parent with a 14-year-old with ASD. They never had obsessive compulsive behaviors before the pandemic, but I imagine that means they are now. And they wanted to know, is this common? Are you seeing any kind of impacts of the pandemic on some of these behaviors?
You know, that's a tough one to answer because I've seen both. I've seen behaviors, and you know, the largely literature talks to this, especially anxiety and OCD, that in a number of individuals, these behaviors are largely increasing, but also, you know, sometimes, you know, they've, you know, for some individuals, they have equipped themselves with the strategy so they're better able to deal with them within the context of the pandemic. So I think it goes both ways.
Okay. This one was, is there any evidence or suggestion that this would be an effective approach for things like skin picking and hair pulling?
That's an interesting one. I mean, we have had individuals with those behaviors. What we try to do within the context of our package is if something like that, because that is sort of an obsessive-compulsive spectrum disorder, right? So we try to provide some recommendations, but also, you know, the length of treatment that's needed for that in most cases. And again, this is where it would be your health professional that would help with this. You know, it would probably be a more focused treatment for those types of behaviors.
Gotcha. This one was, for children who demonstrated the least improvement, what do you think were some of the obstacles or challenges? They were saying maybe parent involvement, severity of ASD diagnosis, cognitive ability, etc.
That's interesting. I think that's something that we need to further analyze. I think that, yeah, it could have been, you know, in terms of the cognitive ability piece, although we did try to individualize as much as possible. I wonder if being in a group treatment for some of the kids was not the most ideal modality, and whether, you know, that would have been better complemented with some individual sessions, which in the case of the trial, we weren't able to accommodate, but could be done clinically.
Okay. This one came in with registration, and the person said, what are your thoughts about adapting like a CBT approach like this for adults?
Oh, absolutely. Absolutely. I think that, you know, this can be done for any, you know, across the lifespan, right? So we published a paper of a 5-year-old, right? You know, we haven't moved into our next, you know, a couple of our next projects are moving into working with adolescents and then further working with adults. There is very limited research when it comes to adults, which is probably what this individual is referring to, but absolutely those adaptations are necessary. But having said that, we need to carefully look at those factors, right? Those sociocultural factors and where that individual is at developmentally, what makes sense for that particular individual in terms of their age, in terms of their cognitive barriers, all those sorts of things. So it would have to be very carefully designed.
Okay. This was another registration question. They were wondering, do you have any thoughts beyond what we've talked about with ASD around OCB's comorbidity with other disabilities?
Yes, I mean, there's a lot of literature around that. It is, you know, attached to, I mean, generally speaking, when I look at kids with ASD and OCB, we also see comorbid anxiety disorders, we see depression, we see ADHD, we see FASD. So, you know, a lot of these things, one point I'd like to just make on that topic is really trying to look at, you know, secondary prevention or early intervention, right? So if we can tackle these early, the literature is pointing to we can get rid of them, right? Or we can get rid of them quicker. When I work with individuals that get old, you know, that are older, often I do find that there are a number of other comorbid diagnoses attached that we also need to deal with within the context of treatment.
Okay, so for our final question, just looking at the time, this one was, they were wondering about resources available in the community. They were wondering, are things available, do you know of things being available through children's mental health centers, or treatments like this mostly accessed privately?
I mean, I think there's a number of private, well, I'd say there are some private practitioners who do work in this area. In terms of OCD itself, I think that's a question that if that person would like to email me, I could provide some resources. I'd like to know exactly what the, the age and so on, so I'm able to direct in the appropriate place. There is one website that comes to mind that I find very helpful, which is the OCD Foundation. So that's one that I would definitely recommend checking out in terms of different resources.
Great. I saw one more come in with our chat, so we have enough time to go to this one, which was, to what degree, if any, was ABA incorporated into the treatment packages, or was it just strictly CBT focused?
So ABA was, I would say, I don't know if I could give a number to it, but like 1/3 of the treatment. So all that function-based piece, and I'm sorry if I had to go through it quite quickly, that was the applied behavior analysis piece. And that piece, it does get quite complex, right? In terms of, we really wanted to get at all of those was so-called operant functions of the behaviors, and then we just designed individualized treatment. So getting at, when I mentioned the communication training or the social skills training, those were all the applied behavior analytic pieces that were put in for particular individuals.
Okay, well, that does wrap up all the time that we have for Q&A. Thank you to everyone who submitted a question. If you submitted a question that didn't get addressed, please feel free to reach out to our speakers directly. I will be including Dr. Vause's email in our follow-up email to all of you tomorrow. And when the manual is available, we'll make sure to connect back with all of you. I now have the pleasure of introducing Dr. Tina Willoughby, the director of the Lifespan Institute, who will provide a few short closing remarks.
Oh, thank you, Jane. First, I would like to thank Dr. Vause and Dana Kalil for taking the time to present about their research. The I Believe in Me, Not OCB treatment package is a great blend of CBT with behavior analytic components, which, as we learned today, clearly allows for comprehensive treatment that provides psychoeducation and equips children and youth with various coping strategies. And as Dr. Vause mentioned, these strategies then become part of children's toolboxes that they can then use for long-term empowerment and change. Second, I want to thank Brock's Faculty of Social Sciences and to the Office of Research Services for providing support to make this event possible. And finally, thanks to all of you who joined us today. The Lifespan Institute has a strong focus on community engagement. And over the last year, we've been working to design these speaker series so that they can serve as a way for our researchers, our partners, and all of you to join together to learn about staying healthy across the lifespan. We'll be posting a recording of today's event online, and we will email all of you when that is available. We will be taking a break from our speaker series over the summer months, but we have a full lineup of speakers for the fall. We will connect with you when registration opens for those events. And on that note, it's time for us to end. Thank you all again. Stay healthy and enjoy your summer.